This is The Science Inside, the show that goes inside the science of major news events. I'm Lutfia Suleiman, and today's topic is surrogacy. Now, we're speaking to infertility specialist Dr. STEPHAN Volschenk, who's from Vitalab Center for Assisted Conception. Good evening.
Good evening, Lucia.
How are you doing?
I'm finding yourself.
I'm well, thanks. Now, to start us off, how big of a problem is infertility in South Africa?
First of all, I'd just like to say thank you very much for having us on the show. Infertility in South Africa is pretty much the same as the rest of the world. If we look at percentage-wise, we would say that 15% of the world's population would ultimately suffer from infertility and therefore would have to visit a clinic for some form of treatment, of which there are many available depending on the diagnosis for the infertility.
Okay, and what kinds of conditions are most common, and what kind of people do the clinics generally affect?
Well, I think it's important to understand there are two kinds of infertility. You get female infertility and we get male infertility, and then we see the combination where we have a problem with both the male as well as the female partner. If we look at the male partner, we can generally divide it into two categories. It would be either congenital, which means that the males are born with a specific problem, or acquired, which means that something happened to them during their life. If we look at acquired, first of all, it is things like, it would be mumps. Mumps after puberty can cause male infertility. Previous genital infections can lead to male infertility. That would be the acquired. If we look at the congenital, in other words, the inborn errors, there are quite a few inborn errors that exist that can lead to a male either producing no sperm at all or sperm of an inferior quality, not having the ability to lead to spontaneous conception. If we look at the female side, again, we can divide it into categories. We can either say it's anatomical. In other words, there's some kind of obstruction in the pelvis itself that hinders the tube from picking up the egg in order to fall pregnant. And that would be things like previous sexual transmitted diseases or other infections, a ruptured appendix. And then other issues in the female would be the dysfunctional egg, where we find that the egg is either not released in conditions such as polycystic ovarian syndrome, which is reasonably common, about 10 to 12% of the world population, and then other conditions such as endometriosis and also conditions that are very important and easily missed, specifically early ovarian aging, where we find that the ovary of the woman is aging much faster than she is, which means that her egg depletion happens at a far more rapid rate. I think it's important to understand the fundamental difference between males and females are the fact that males will produce fresh, healthy sperm from the age of 13 until we die, actually, whereas women do not really produce one single egg in their entire life. They are born with the group of eggs that they're going to have, and the only thing that happens to those eggs is the fact that they will get less and they will get older until they run out of eggs and then go into a condition that's commonly known as menopause.
Okay, let's talk for a second here about the effect that age has on your ability to conceive. I mean, like you mentioned, there's a common conception that women have a so-called ticking biological clock, while men don't. Is that medically valid?
That is absolutely true. Women are generally at the most fertile at the age of 26. That's really as good as it gets. And if we have a woman that's 26 with absolutely no problems whatsoever, and the male partner has got no problems whatsoever either, the likelihood of falling pregnant per month that they attempt to conceive is no more than 18%. That's as good as it gets, which means that if she tries religiously for 12 consecutive months, there's a 92% chance that she will be pregnant after 1 year of trying. So 18% is not the highest numbers that you can think of, versus, if we take for argument's sake a 40-year-old, the fecundability, the likelihood of falling pregnant, has now decreased from 18% per month all the way down to 3 to 5% per month. So it becomes a whole lot more difficult to fall pregnant. Miscarriage rates much higher because the eggs are more abnormal and they're older now. And on the other hand, the male really keeps going on until he dies. The only thing that changes is after the age of roughly 46, the amount or the volume of sperm will decrease, but the quality and quantity generally is stable. So that's the difference between males and females. The biological clock is a very important thing. And in today's society, in 2015, where it's very important to have a degree and to see the world and then to have your babies, that's why infertility units are so busy, because the majority of patients that we see nowadays are patients that are older than 35 and they really struggle to fall pregnant, and it's purely an age-related thing.
Okay, now is what we're seeing now in terms of infertility similar to previous decades, or are there changing trends? I mean, is there a higher rate of infertility at a younger age, or more of a certain condition?
It's all about perception. In 1910, by the age of 26, the family was finished, done and dusted, and life moved on. And like I said, nowadays we have to have a career first, travel the world a few times, and then by the time we reach the age of 35 or 38, we wake up and say, oh my gosh, we forgot to have children. And so it's purely a perception. It is not really the fact that infertility is increased. It's the lifestyle and the way we live our lives nowadays.
Okay, now obviously every case is different, but can you walk us through some of the main methods that you use to help couples conceive?
I think it's important, first of all, to understand that infertility is not a diagnosis. It's a symptom, and it's a symptom of an underlying condition. So if you struggle to conceive, and let's just look at the definition first of all, the definition of primary infertility, which means the inability to conceive, would be the inability to conceive after 12 months of regular unprotected intercourse. After the age of 35, that 12 months will come down to a period of 6 months. So if you are in those two groups and you've been struggling, then you qualify according to the definition. And then it is important to understand that it is not a diagnosis, it's a symptom, and therefore you need to go and get professional help to make a diagnosis, because your treatment will depend on the diagnosis that is made. And the treatment can vary from just straightforward timed intercourse, whereby you're not quite sure when you should have intercourse, because it's important to remember the window of conception is really only 72 hours every month, which is 3 days, and if you miss it either one day or the other day, you would have missed that month and you need to move on to the next one. So it can be either as simple as timed intercourse, or if there's a mild male factor, we talk about inseminations, whereby sperm is washed, concentrated, and then injected into the uterus, right through the spectrum of in vitro fertilization, intracytoplasmic sperm injection, commonly known as ICSI, where we have such a severe male factor that the sperm count and concentration is so low that each and every egg needs to be injected with a sperm. And then we can move on to the fact that we can use donor sperm in cases where males do not have any sperm, or egg donation in cases where the woman has actually run out of eggs. That's basically the treatments that we have available.
Okay, great. Now, your center houses South Africa's first frozen egg bank. Can you tell us a bit more about
Correct.
that?
Egg freezing is the future from two perspectives. First of all, for fertility preservation, meaning that we want to have a life, we want to have a career, we want to do a few things before we have children. And therefore, from a fertility preservation perspective, egg donation is really the new kid on the block, and that's the future. Literature is clear nowadays that if you want to bank your eggs and freeze them so that you can finish your career and whatever else you need to do first before you start a family, it should really be done before the age of 36. After the age of 36, pregnancy rates are not that great. So people would be encouraged, if they think that that's the way their life's going to turn out, to bank their eggs early, to freeze them. The technology is extremely robust. And thereby they can preserve their fertility and utilize the eggs whenever they are ready to use them.
Okay, so that would be, that's the egg is then used in the same woman who's frozen her eggs, so it would be implanted.
And the important thing to understand is if you decide that you want to bank your eggs, for argument's sake, at the age of 27, and you're only going to use them at the age of 35, the beauty of the concept is the fact that those eggs do not age. They are frozen, they're suspended in time. So if you freeze them at the age of 27 and you decide, well, I'm going to use them at the age of 35, you ostensibly still have the same potential to fall pregnant that you had when you were 27 years old. That's the beauty of the technology.
Okay.
Egg freezing is also important with regards to egg donation. The world is moving away slowly but surely from fresh donations because of the fact that it's very difficult and it's very expensive. So slowly but surely the world is moving towards egg banking with regards to egg donation as well, where egg donors will come and donate the eggs altruistically, and then those eggs will be frozen and they will be kept in an egg bank like sperm is kept in a sperm bank, which makes future use much easier.
Okay, and what new technologies or advances are interesting in this field of infertility treatment?
I think the interesting thing, or the buzzword nowadays, would be pre-implantation genetic screening or pre-implantation genetic diagnosis. The difference between the one is in the pre-implantation genetic screening, we have the ability to take embryos that are generated through IVF or ICSI and analyze them to see whether the complement of chromosomes are normal, because the normal embryo will lead to the highest pregnancy rate. And then we also have couples with specific genetic conditions, and they would like to have offspring that does not have the same problem, in other words, the same genetic disease. And those embryos can be screened and the diagnosis can be made, and embryos that are unaffected can be transferred back into the uterus, which gives the couple the reassurance that the child that they are going to have will be disease-free. Those are the real buzzwords nowadays. I mean, medicine is very dynamic and infertility is extremely dynamic, so every day there's something new. But our new tool in the arsenal today would be the PGS, the pre-implantation genetic screening and diagnosis.
Okay, so it sounds like there's a lot of options for someone who is suffering from infertility, or maybe just wants to make sure that they don't pass on a genetic disorder to their kids.
Absolutely. That's the beauty of what's happening.
Great. Thank you very much, Dr. STEPHAN.
Thank you so much.
Thanks for coming on to the show.
Pleasure. Bye.
Bye.